Well, thank you very much and good morning. You know, we've been hearing a lot about transplant, dialysis, and what have you. I'm on the other side of the bell, try to prevent all of that stuff from happening in the first place. And so just to give you a background, the clinic that I work in and direct is a referral clinic for people almost exclusively with diabetic kidney disease that have severe, difficult to control blood pressure. And our goal is to delay decline in kidney function. And I was privileged, and you saw this earlier, I was privileged to be on the development and steering committee of the Credence trial, which you saw, which is the first major advance in terms of slowing kidney disease in over 20 years, as you heard. So what does blood pressure play a role in? Before we had the onslaught of diabetes, which really started about 25 years ago with obesity epidemic, hypertension was by far the most common cause of kidney failure and still is competitive with diabetes, even though it's fallen to number 2. So let me start off and give you a brief review here, because I serve as a guideline writer not only for the American Heart Association, but also for the American Diabetes Association and also the KDIGO, which is the International Kidney Guideline Committee. So I've interacted with a whole bunch of different people coming at this from a different mindset, heart-focused, kidney-focused, and metabolic-focused. And it's amazing how you can take the same data and come up with slightly different conclusions, which is what happened this year, or 2 years ago when they came out. But I want to give you the history of where these guidelines come from so you appreciate where blood pressure guidelines come from. And they started back here at the NIH with a lady named Mary Lasker, who in the early 70s had a stroke and realized her doctors had no clue how to treat her in terms of blood pressure. So she gave a grant to the NIH for $2 million, whose job it was to put together a group of experts to come up with some guidance for physicians. And so that was the first J&C, came out in 1977. And you can see there, because I'm assuming most of you know about blood pressure goals, you would consider therapy if your diastolic blood pressure was 105. You'd consider therapy. Now people would be in the emergency room. So it's a different mindset, and you can see the evolution through the different J&Cs all the way to the current one, as to things have all steadily moved downward and there's been modifications. Diastolic blood pressure is important in terms of predicting mortality if you're under age 50. And I don't have time to get into that with you, but there's a seminal paper published in 1997 in Circulation that shows that. If you're over 50, it's the systolic blood pressure that's the determinant. There were no guidelines for systolic hypertension until the JNC3, and that's because there were really no good trial data. So this is an evidence-based kind of approach, and as more evidence has come to the front, less opinion is there and more evidence is there. So that gives you the history. As you can see here, hypertension is still number 2 as a cause for going to kidney failure and dialysis. Now, the one thing that's new in these guidelines, although the other guidelines talked about it, it's front and center in this guideline, it's front and center in the European guidelines, and that is, let's move away from the numbers a little bit and let's focus on what your risk is, because the higher your risk is, the more benefit you're going to get from a lower pressure. And so basically what they've done is the epidemiologists really did a stellar job of going through, looking at clinical data, and while the data uniformly supports a 15% 10-year risk for cardiovascular events, the data there is overwhelming, they wanted to instill kind of a CERTS approach to guidelines. Remember CERTS, the breath mint, 2 mints in 1? I'm old too. So it turns out that they said, look, let's not ignore the young people. So if you're at 10% 10-year risk, then you should be in the same boat and everybody should be treated. And so where should you be treated to? Well, they came up with less than 130, and I won't get through all the data for you because that's a whole separate talk. But the data for that was pretty solid, especially if you have a history of coronary disease, diabetes, advanced kidney disease, overwhelming data supporting this. So it was kind of easy to come up with that. And of course, in approaching this, what happens with many physicians, because again, they're not paid for this, although they all know it, No one sits down and educates the patients about low-salt diets, exercise, and those kinds of things. A, because they have an attitude that the patients won't listen, and B, they're not getting paid for it, it's extra time, and there's somebody with a gun in their head that wants you to crank patients out. Now, how do I know this? Because I'm number 4, doc number 4, that ultimately they end up on my doorstep. So they've already seen the cardiologist, they've already seen the general internist, and in many cases they've seen the nephrologist. I ask them what they know about sodium intake, don't use any. Okay. Any specifics? No. So it takes time to do this, and as I tell them, properly done, that's worth 1 drug. Easily, and in some cases 2 drugs. So it's very important to do that. Smoking, I'm not going to waste your time. Obviously, if you're, a little plump, you should probably work to try to become less plump, especially if you have a family history of diabetes, because you're going to be in big trouble. And so the modifiable risk factors are really harped on that really need to be educated on the patient side. There is a calculator that was devised, the ACVD risk calculator, and this calculator is a freebie. You can download it. It's not perfect, but it is validated, and it gives you, as long as you're kind of between 40 and 79, a very good idea of your risk. And all you got to know is your age, sex, cholesterol values, whether you have diabetes or not, whether you have hypertension or not, and then what's your race. And you put that into the equation, and you get what your 10-year cardiovascular risk is going to be, and then actually, if you plug in that you fixed the things that are problems, it then tells you what your new risk is. And this is very powerful to show the patient, because if there's any question about taking meds, remember, everybody talks about hypertension as a silent killer. Let me remind you, kidney disease is a silent killer. And that's the problem, because most patients, and we just presented this data at the Kidney Foundation meetings in Boston a couple of weeks ago, 60% of people with stage 3 CKD have no clue that they have CKD. That's a big problem. So I'm a big fan of having the patient be their own advocate, but how can they be if they're not educated? And it's up to the doctor to educate them. So the other thing is that's big in the guidelines is blood pressure measurement. People come in, they're in a hurry, the nurse, you got your coat like this, they'll put the cuff around here, they'll check the blood pressure, and off you go. Yeah, that is about a -10 in terms of grades, because that is not what you're supposed to do. And there are specific guidelines on how to measure pressure. Those are really harped on big time. Again, not practical, because they take extra time to do properly. And the good news is, if you do them properly, you will avoid indiscriminately giving medication to people that have white coat hypertension, that is high pressures in the office that are normal outside, and you'll avoid side effects. So there's a lot of reasons to do this correctly. It's not just academic, but again, timing is an issue. Out-of-office blood pressures. The patients are instructed to take charge of their own disease. So go home, get a blood pressure cuff. They should be educated as to how to measure their blood pressure at home and when to measure it at home, and give data to the physician. I do this routinely, and what I've realized is I don't need to worry about adherence, because the patients that are sending me all the data do amazingly well. The ones that don't send me data, I already know they're not taking their meds or they're not following the diet. It's a no-brainer. And I've actually confronted them, and they've admitted it. So it's cheap adherence measures. Now, white coat hypertension and mass hypertension are very important, and I just want to quickly mention this. White coat you know about. A lot of people think, it's not a big deal, I'm just nervous. It kind of is a big deal. And I'll show you some data in a minute. Mass hypertension, even more nefarious, because you have a normal blood pressure in the office, but you're in a high-stress job. You're an engineer, you're working on the board of trade, you're doing something that's heavily analytical, time-pressured, intense, and your pressure can go up. And you would never know it unless you had some kind of misfortune of having a stroke or having a nosebleed or something like that. Now, this is data taken from a registry in Spain of about 60,000 patients. And they looked at cardiovascular mortality and all-cause mortality. I'm showing you all-cause mortality for white coat hypertension is 2.2-fold higher than someone who's normotensive. And if you have mass hypertension, it's almost 3-fold higher. And look at this. If you have sustained hypertension, white coat hypertension, sustained hypertension, not a difference. Very important. Now, that's for all-cause mortality. And if you look at cardiovascular mortality, trends are very similar. So it is important to measure home blood pressure, and it is important that if you're in a high-stress job, to make the physician aware that you're in a high-stress job and you think your pressure may be elevated, because you yourself can actually check your pressure at work just to see if it in fact is elevated. And I can give you anecdotes about that later. This was put in the guidelines that I think is critically important, and I recommend it to all nurse practitioners and PAs and everybody. Xerox this and give it to all the patients, because it tells you not just what the recommendation is, but gives you specifics and tells you how much blood pressure reduction you're going to get if you actually follow these things. And this is where I get the thing that it's worth one blood pressure medicine, because in some cases, if you do all this and do it well, it could be 2 blood pressure medicines. Now, how can you look at all the same data and come up with different conclusions? Well, a lot of this has to do with patient perception as well, or what physicians think the patient perception is. So in the US, we don't care. You will do it this way, and I'm sorry, it's for your own good. So shut up and just do it. Less than 130/80. But I don't feel good at 130/. I'm sorry, it's too bad, got to do it. In Europe, they're like, listen, less than 140/90, we have 60 years worth of data that says this is good. And how much better is less than 130/80? Well, if you're very high risk, diabetes, advanced kidney disease, both, advanced heart disease, yeah, it is better. But forget about that. We're not talking about that. We're talking about Mr. Jones, who doesn't have kidney disease, doesn't have heart disease, has his cholesterol controlled, is doing fine, is exercising, is watching his salt, and his pressure's 134/82. Are you going to call him hypertensive? Well, the Europeans, the Latin Americans, the Asians would all say no. So it's very important to understand where this is coming from. You cannot force feed a preventive strategy and a treatment strategy for people with advanced disease and put them in the same document and say it's good for everybody, because there are real issues with that. So I just want you to understand that there is not equipoise in terms of the numbers, and there are good debates, and in fact, I debated the chair of the guideline committee and won by a narrow margin, even though in their hearts, these were cardiologists that really, for them, they want you at 120, but it's a mindset. So you really have to look at the data to be careful. Now, a couple of other things. We have been saying in the guidelines since 1996 that you should be starting with 1 pill, 2 drugs in people that have 20/10 blood pressures above their goal, and the goal was 140/90. It has never caught on because hospitals don't use combinations, and the funding agencies and CMS say, well, that's just a convenience, forget it. And so we're not going to do that. Get the individual pills and just take it. So patients, you've already heard, are taking 12 to 16 medicines with advanced kidney disease. I can tell you that they very much appreciate taking fewer numbers of pills. Very important. And there's great arguments for that. And again, this was in JNC 7, it was in JNC 8, and now it's in the ACC-AHA guidelines. The Europeans start with combo therapy. They don't care what's going on. You need to be treated, you get 2 pills. Why? Because they figure you're not going to take anything, so if I just give you 1 pill with 2 meds at low doses, you're going to be in better shape. And they actually have very good data to support that. So I think it's important to know there's a difference in the approach based on data of adherence in different populations to get to the goal. And even there, where it's less than 140/90, they're still advocating single pill, low dose combination. Now, kidney disease, very specific finally, because in the day, everybody was putting ACEs and ARBs in the drinking water. There's 0 data to support that that does anything beneficial in terms of very early stages of kidney disease. However, the data is overwhelming. If you have 300 milligrams or more of albumin, control of blood pressure to levels of less than 130 clearly has benefits not only on the kidney, but to cardiovascular disease. If you go below 130, there's no further benefit to the kidney, but there's benefit on reducing cardiovascular events. These are 3 randomized trials that basically showed no benefit of lower blood pressure on slowing progression of kidney disease. None of these people had diabetes. These are all people that had non-diabetic kidney disease, hypertension, IgA nephropathy, etc. All of them showed cardiovascular benefit. SPRINT was not powered for renal outcome, which was the most recent one. But again, like the others, it showed benefit on slowing progression of kidney disease. And if you got below 130, there was a cardiovascular benefit as well. So very important point. The ADA has basically said that the ADA and the ACC, for the first time in history, have agreed to accept each other's guidelines. And the ADA basically says less than 130 over 80 for almost everybody, but there's a subgroup that can't tolerate that or has some other reasons not to be there, and so less than 140 is the goal. So I think, again, an important point to keep in mind, and this is very strong evidence, and if you have diabetes and if you have a proteinuria of greater than 300, you have to be on an ACE or an ARB. If you just have diabetes and no kidney disease, nobody says you have to be on an ACE or an ARB. If you want to use one, fine, but there's no mandate that you have to be on it. Now, I just want to make a point quickly about blood pressure levels and differences between those with diabetes and those without. This was a study, epidemiologic study of 19,000 people, looking at people with diabetes and looking at people without diabetes. And you can see here that the arrow is pointing to about 130. And so there you go. If you get down to 130, you're fine. But then what happens, and that's the hazard ratio for mortality on the y-axis. What happens when you get below 120? It goes up pretty high, pretty quickly. If you look at those without diabetes, there's no problem at all. You can go down to 110, life is good. Now, there's a number of speculations as to why this is true, but I think it's important to know. And I can show you 4 other studies show the same thing. So one size does not fit all, and you do need to understand your disease process. This is for people that are older, shall we say, vintage. So 65 to 79 and then over 80. And you'll notice that in most of those boxes, there's the little term, if tolerated, if tolerated. So you're working with the patient to get their pressures down to 130. Many people with very stiff vessels that are old will not tolerate it. And so there's no reason to push. And there's no evidence that you get a benefit in that subgroup. So very important point. This is just to let you know that if you overtreat, if you've got people at very low risk, the benefit is actually going to not be very good and the side effects are going to be higher. So you need to select people at very high risk that you're going to treat, and those people should be aggressive. The people at very low risk, you don't need to be that aggressive, and less than 140 is fine, and this is one of 4 reports that came out looking at this. So just to finish, there's no strong data supporting less than 130 over 80 to slow CKD progression. So if you're focused on the kidney, then unless you have a gram of proteinuria, unless it was really advanced kidney disease, there's some soft data supporting that. But otherwise, it's cardiovascular benefit that you're getting. For cardiovascular risk, definitely less than 130 over 80. And then if you look at the major guideline, less than 130 over 80 is what's recommended in people with diabetes and in people with kidney disease. Everybody else, you really have a hard time going to that level for the just small additional benefit that you're going to get. And lastly, you should not put ACEs and ARBs in the drinking water because they really have only been shown to be a benefit, at least for the kidney, if you have either heart failure or if you have greater than 300 milligrams of albuminuria. Thank you very much.